Welcome back to the Deep Dive. Today we're unrolling a truly fascinating blueprint of the human body.
Yeah, and our source might seem a bit academic at first glance.
Right, it's Anatomy Revision Edition 8.pdf. But honestly, trust me on this, it's way more than just a textbook. Think of it like a treasure map to understanding how you're actually put together. Our mission for this deep dive is to pull out the most surprising, the most clinically vital, and frankly, some of the real head-scratching insights from all this anatomical knowledge.
Sort of a shortcut, really.
Exactly.
Right.
We want to give you those aha moments,
Mm-hmm.
where complex anatomy suddenly clicks, whether it's why a certain condition happens or even just how you tie your shoes.
And that's the key, isn't it? It's not about just memorizing parts lists.
No.
It's about getting that foundational why. Like
Yeah.
how your earliest development shapes your adult body, and how even tiny, tiny changes or specific injuries can have these massive, sometimes really unexpected effects. These are the insights that make the body feel, well, alive. We really want you thinking about the interconnectedness of it all. It's quite incredible.
Okay, so let's start right at the very beginning then. That journey from, well, just a few basic dew prints to the amazing complexity of an adult.
The embryological marvels, yeah.
And what happens when that building process goes a bit awry?
It's kind of mind-blowing how precise these steps are, right? Starting from just a few cell types.
Totally. And they dictate everything, from the tiny bones in your ear to exactly where your organs end up.
Understanding the precision really helps explain why certain conditions pop up later.
Absolutely. It gives you that link.
Okay, think about those basic germ layers. Ectoderm, mesoderm, endoderm, the original architects.
The foundation.
But what often gets glossed over is the sheer variety that comes from things like the neural tube.
Right, the CNS creator. Brain, spinal cord.
Even the oligodendrocytes, the cells insulating your nerves.
But then even more surprising, perhaps, are the neural crest cells, NCCs.
Ah, yes, the great migrators. Exactly. They start at the edge of the neural tube and just go everywhere. They're like biological Swiss Army knives.
So what do they actually become? It's a lot, isn't it?
It's an amazing range. Your entire peripheral nervous system, all the ganglia, the Schwann cells doing insulation out there,
Okay.
but also parts of your adrenal glands, the C cells in your parathyroid making certain hormones, all your skin pigment cells, the melanocytes,
Wow.
and even loads of your skull bones, the dentine in your teeth, cartilage in the pharyngeal arches. It's just astonishing. One cell type doing so much.
That diversity is incredible. Okay, speaking of foundational structures, let's talk about the diaphragm.
Ah, the breathing muscle.
Yeah, but we usually just think of it as one big muscle, right?
Yeah.
Anatomically, though, it's a fusion.
A developmental puzzle. Comes from 4 different bits.
Right, the septum transversum, those two pleuroperitoneal membranes.
The body wall mesoderm, the cervical somites, and the esophagus's dorsal mesentery.
And this complex origin, it has direct clinical importance.
Huge importance. Take congenital diaphragmatic hernia, a really serious condition.
What goes wrong there?
Well, basically, one of those building blocks, the pleuroperitoneal membrane, just doesn't form properly. It leaves a gap.
And things can push through.
Exactly. Intestines push up into the chest, usually on the left side.
Oh, wow.
But the real danger isn't just the displaced organs, it's that the lungs don't have space to grow. Lung hypoplasia.
So underdeveloped lungs.
Severely. It shows how one developmental slip can have these massive, life-threatening consequences.
It really drives home the importance of that early development. Okay, another master plan. The pharyngeal arches in the head and neck.
Yeah, core structures.
Yeah.
Mesoderm inside, ectoderm outside, endoderm lining.
And the things that develop from them are just, well, amazing.
They are really specific. Like, the first arch gives us Meckel's cartilage.
Which forms?
Well, it contributes to the malleus and incus, 2 of your tiny hearing bones and your whole jawbone, the mandible.
Incredible.
And the other arches. The 4th and 6th are key for your voice box, the laryngeal cartilages.
Okay. And the clinical link here.
DeGeorge syndrome is a classic example, often caused by a tiny deletion on chromosome 22q11.
And that affects.
It messes up the development of the 3rd and 4th pharyngeal pouches, so you often see things like an absent thymus gland affecting immunity and hypoparathyroidism messing with calcium levels.
A clear link between a developmental error and a specific syndrome.
Exactly.
This also helps explain one of anatomy's classic puzzles, doesn't it? That weird path of the recurrent laryngeal nerve.
Yes, why the left one dives way down into the chest.
And the right one doesn't. What's the story there?
It's all down to how the embryonic arteries develop, specifically the aortic arches. The left RLN gets hooked under the sixth arch artery,
Well, becomes.
the ligamentum arteriosum in the adult. Since that structure stays, the nerve gets pulled down with it on its long journey.
Okay, that makes sense for the left and the right.
Well, on the right side, the fifth arch artery and the distal part of the sixth arch artery mostly disappear during development.
So nothing to hold it down low.
Exactly. It ends up hooking just below the fourth arch artery, which is higher up, so a shorter course.
Seems like a random detail, but I guess for surgeons.
Oh, absolutely critical. Knowing exactly where that nerve runs is vital during neck and chest surgeries to avoid damaging it.
Right. Okay, one last embryology point. The midgut's journey. It does this whole rotation thing during development.
A very precise 270-degree counterclockwise rotation, normally.
But what if it doesn't rotate correctly?
That leads to some significant anatomical variations. Problems, potentially.
Like what?
Well, you could have non-rotation. The small intestine ends up mostly on the right, large intestine on the left. Or reverse rotation.
Reverse.
Yeah, the transverse colon ends up behind the main artery, the SMA, instead of in front. These might not cause issues immediately, but they can predispose you to things like volvulus bowel twisting.
So those early steps are crucial for later function and safety.
Absolutely. It's just fascinating how these precise steps, starting with so few cells, orchestrate everything. The ear bones, organ position.
And understanding that helps make sense of why things go wrong sometimes.
Exactly. It gives you the why behind the condition.
Okay, so from those blueprints, let's move into the adult body's hidden architecture. We're talking vital spaces, vulnerable nerves, the stuff that really matters clinically.
Yeah, this is where the diagrams become a living map. Understanding these spaces, vessel pathways, it's not just academic.
No, it explains real symptoms, guides procedures.
It can literally save lives, or at least solve puzzling signs. It's about connecting those hidden dots.
Let's start in the thorax, the chest, those intercostal spaces between the ribs. There's a specific layout there, right?
Oh yeah, very predictable. Vein, artery, nerve. Always superior to inferior, tucked under the groove of the rib above.
Okay. And that's not just for exams, is it?
Definitely not. Think about a pleural tap draining fluid from the chest.
Yeah.
You always aim the needle over the top edge of the rib below the space you want to enter. Why? To avoid hitting that van bundle running under the rib above.
Makes sense. Keeps the vessels and nerves safe.
Precisely. And similarly, for an intercostal nerve block, you'd target the lower border of the upper rib, closer to the nerve. Knowing van is just fundamental safety.
Okay, now for a really interesting twist. The internal thoracic artery. It runs down the chest wall.
And eventually splits into the superior epigastric and musculophrenic arteries, usually around the sixth intercostal space.
But in a specific heart condition, coarctation to the aorta, something amazing happens.
Postductal coarctation, yeah. It's where the aorta is narrowed after the ductus arteriosus connection.
So the body needs a workaround for blood flow.
Exactly. And it finds one. Blood flow actually reverses in the intercostal artery.
Reverses? How?
It goes from the internal thoracic into the anterior intercostals, then backwards into the posterior intercostals, and then into the descending aorta beyond the narrowing. It's a natural bypass.
Wow. And that causes...
These collateral arteries become huge, engorged, tortuous because of the high flow over time. And on an X-ray...
You see it.
You see rib notching. The enlarged arteries literally erode the undersurface of the ribs. It's a classic sign of the body adapting. Incredible adaptation.
That really is incredible. Okay, Let's shift down to the abdomen, the peritoneum, that lining. It creates folds and pockets, right?
Like the falciform ligament connecting to the liver, the gastrosclenic ligament, and the lesser omentum.
And the lesser omentum is important because...
It contains the portal triad, the portal vein, hepatic artery, bile duct heading into the liver, very important structure. And there's also that key connection point.
The epiploic foramen.
AKA the foramen of Winslow, yes. That's the doorway between the main peritoneal cavity, the greater sac, and the smaller pocket behind the stomach, the lesser sac.
Clinically, though, what's important about these spaces?
Gravity. Understanding where fluid collects. The most dependent sites.
Where things pool.
Exactly. If you're lying flat, supine fluid, like blood or pus, will collect in the hepatorenal pouch, Morrison's pouch, between the liver and right kidney.
Right. And you're sitting up.
Then it cools lower down. In the rituterine pouch in females, between rectum and uterus, or the rectovesical pouch in males, between rectum and bladder. Knowing this tells clinicians where to look for trouble.
Simple physics, but vital information. What about the perineum down below? It has layers too.
It does. Superficial and deep perineal pouches, separated by the perineal membrane. Fascial layers are key here.
How so?
Well, imagine an injury to the bulbar urethra, part of the male urethra. If urine leaks out, extravasates.
Where does it go?
It escapes into the superficial perineal pouch, but because of the fascial attachments, it can spread up onto the lower abdominal wall, into the scrotum, down into the thighs.
But not everywhere.
Right. It won't typically spread back into the anal triangle or down the legs proper because the fascia contains it. Understanding these compartments is crucial.
Okay. And that horseshoe abscess thing.
The ischiorectal fossa, that fatty space beside the anus. An abscess there can actually spread across the midline, behind the anus, to the other side, forming a horseshoe shape. Again, fascial planes guide the spread.
Fascinating. And a bit scary.
Mm-hmm.
Okay, up to the head now. The cavernous sinus. Sounds ominous.
It's a really critical junction box, basically. A venous sinus, but loads of important stuff passes through it or right beside it.
Like me.
The internal carotid artery runs right through it, and cranial nerve 6, the abducens nerve controlling eye movement, travels with it. Other cranial nerves run in the wall.
So a busy intersection. What's the big clinical implication here?
If that internal carotid artery ruptures inside the sinus, say from trauma or an aneurysm,
What happens?
you get a carotidocavernous fistula. High-pressure arterial blood pours into the low-pressure venous sinus.
And the effect?
The arterial pulsations get transmitted through the sinus and the veins draining the eye. The result is pulsatile proptosis, a bulging eye that actually pulses with the heartbeat, a very dramatic sign.
Wow, you definitely noticed that.
Yeah.
Okay, last stop for this section. The pterion, that spot on the side of the skull.
Yeah, that H-shaped junction where 4 skull bones meet, frontal, parietal, temporal, squamous part, and sphenoid greater wing.
Looks like just another bony landmark, but it's critically important, isn't it?
Extremely, because lying directly underneath it on the inner surface of the skull is the anterior division of the middle meningeal artery.
The MMA.
Exactly, and a fracture at the pterion, even from what seems like a minor blow to the temple.
And tear that artery.
Precisely, and that leads to an extradural hemorrhage, a bleed between the skull and the dura mater, the brain's tough outer covering.
Yeah, it's bad because...
It's arterial bleeding. It can accumulate very rapidly, compress the brain, and become life-threatening very quickly. So that small area, the pterion, is a major vulnerability.
It really shows how knowing these specific locations and relationships is just essential.
Yeah.
It connects the anatomy to real-world dangers and diagnoses.
That's exactly it. Connecting those dots.
All right, let's move on to our limbs, the arms and legs. We'll dive into some common nerve injuries and look at the functional bits that let us move and feel.
Yeah, this is where anatomy gets really practical for understanding movement problems. Knowing which nerve does what is key to figuring out what's gone wrong after an injury. It's your diagnostic roadmap.
Okay, upper limb first. Brachial plexus injuries, that big nerve network in the shoulder. Let's start with Erb's palsy.
Right, that's typically an injury to the upper trunk of the plexus involving the C5 and C6 nerve roots. Often happens during difficult childbirth.
What does it look like? What's the effect?
It knocks out muscles around the shoulder and elbow, mainly supplied by the axillary and musculocutaneous nerves. So you get that classic policeman's tip or waiter's tip posture.
Describe that.
The arm hangs by the side, shoulder adducted, internally rotated, elbow extended, forearm pronated, wrist flexed, like someone waiting for a tip behind their back.
Got it. Okay, what about the other end of the plexus? Klumpke's palsy.
That's an injury to the lower trunk, C8 and T1 roots. Maybe from grabbing something while falling or a difficult birth pulling the arm upwards.
And the result there?
This affects the nerves going down to the hand, mainly the ulnar and median nerves. So you get paralysis of the small intrinsic hand muscles.
Leading to?
A complete claw hand. Hyperextension at the MCP joints, knuckles, and flexion at the IP joints, finger joints, for all fingers.
And sometimes more.
Yeah, because T1 carries sympathetic nerves to the head and neck. You can also get Horner syndrome on the same side. Droopy eyelid, constricted pupil, decreased sweating.
Okay, moving down the arm, the radial nerve. Seems like it gets injured a lot.
It does. It has a long, winding course. It can be compressed high up in the axilla, crutch palsy.
Right.
Or in the spiral groove of the humerus, where it runs right against the bone, classic Saturday night palsy if you fall asleep with your arm over a chair.
Or lower down.
Yeah, fractures around the elbow, like the lateral epicondyle can get it too.
But the main sign is usually the same.
Pretty much always wrist drop. The inability to extend the wrist and fingers because the extensor muscles are paralyzed.
So how do you tell where the injury is?
By the pattern of sensory loss. Higher injuries affect sensation more extensively on the back of the hand and forearm. Lower injuries might spare some areas.
Makes sense. Okay, median nerve. Carpal tunnel syndrome is the famous one, right?
Yeah.
Entrapment at the wrist.
Definitely the most common median nerve issue, but injuries higher up can happen too.
And what's the effect then, besides the carpal tunnel symptoms?
It affects most of the hanar muscles, those muscles at the base of your thumb. The main one spared is adductor pollicis, which is usually ulnar nerve.
So trouble with the thumb.
Big trouble. You lose the ability to oppose the thumb, bring it across to touch the fingertips. That leads to the ape thumb deformity, where the thumb lies flat in the plane of the palm.
And that pointing index sign.
Ah, yes, the hand of benediction. If you ask someone with a high median nerve injury to make a fist, they can't flex their index and middle fingers properly because the lateral half of flexor digitorum profundus and all of flexor digitorum superficialis are knocked out. So those fingers stay straighter, pointing out.
A very distinct sign. Okay, ulnar nerve. What happens when that's injured?
Injury, often at the elbow or wrist, leads to the ulnar claw hand.
How's that different from Klumpke's?
It specifically affects the fourth and fifth digits, the ring and little fingers. You get that same hyperextension at the MCP joint and flexion at the IP joints, but mainly in those two fingers.
Got it. And the Froment sign. What's that testing?
That's a neat test for ulnar nerve function, specifically the adductor pollicis muscle, which pulls your thumb towards your palm.
How does it work?
You ask the person to hold a piece of paper firmly between their thumb and index finger. If adductor pollicis is weak, they'll compensate by strongly flexing the very end joint of their thumb, using a median nerve muscle, flexor pollicis longus. That thumb flexion is the positive Froment sign.
Clever. Now explain the ulnar paradox. Sounds intriguing.
It is a bit counterintuitive. The paradox is that a lower ulnar nerve injury, say at the wrist, results in a more pronounced claw hand deformity than a higher injury at the elbow.
Wait, lower is worse. Why?
Because with a high injury at the elbow, you also paralyze the ulnar part of the flexor digitorum profundus, FDP, the muscle that flexes the tips of the fourth and fifth fingers.
Okay.
So with a high lesion, the fingers are less flexed, the claw is less obvious. But with a low lesion at the wrist, the FDP muscle is still working fine.
Ah.
So it pulls the tips of the fourth and fifth fingers into strong flexion, unopposed by the paralyzed intrinsic muscles, making the claw deformity much more prominent.
So the paradox is that sparing a muscle makes the overall deformity look worse.
Exactly. It highlights the interplay between different muscle groups.
That's a great clinical pearl. Okay, let's quickly touch on those intrinsic hand muscles themselves, the lumbricals.
The tendon-to-tendon muscles. They originate from the FDP tendons and insert onto the extensor hoods.
And their action.
They do that clever movement, flexing the MCP joints, knuckles, while extending the IP joints, finger joints, like making an L shape with your fingers or during writing.
Crucial for fine motor skills. And the interosi.
Essential for spreading and closing the fingers. And we have that great mnemonic.
PAD and DAB.
You got it. Palmar interossei adduct bring fingers together. You can test this with the card test, seeing if they can hold a card between their fingers.
Okay. And DAB.
Dorsal interossei adduct spread fingers apart. Tested with the Agawa test, resisting abduction. Simple mnemonics, but really helpful.
Definitely helps remember their function. Okay, let's walk down to the lower limb. Gait and stability. Trendelenburg sign. What does that tell us?
It's a classic sign of weakness in the hip abductor muscles, specifically gluteus medius and minimus.
And what nerve supplies those?
The superior gluteal nerve. So injury to the nerve or damage to the muscles themselves causes this.
And what do you actually see?
When the person stands on the assected leg, the pelvis on the opposite unsupported side drops down.
The contralateral drop.
Right. And often they'll compensate by lurching their trunk towards the weak side, an ipsilateral lurch to try and keep their balance. It's a very common sign in neurology and orthopedics.
Clear indicator of hip abductor weakness. Okay, common peroneal nerve. Where's its danger zone?
Right where it winds around the neck of the fibula, just below the knee on the outside. It's very superficial there.
So easy to injure.
Very. Direct trauma, fracture of the fibular neck, even prolonged pressure like from a tight cast or crossing your legs constantly.
And the result of injury.
Foot drop. Big time. You lose the ability to dorsiflex the foot, lift it up, and avert it. Turn the sole outwards.
So the foot just hangs down.
Yep. And often turns inwards slightly. Inversion. To compensate when walking, the person has to lift their knee really high to avoid tripping over their toes. It's called a high stepping gait or steppage gait.
Another very characteristic sign. Finally, the foundation. Arches of the foot.
We have the medial and lateral longitudinal arches, giving that spring and shock absorption.
And what holds up that main medial arch?
Several things, but a really key player is the plantar calcaneonavicular ligament, better known as the spring ligament.
Spring ligament. And what does it do?
It forms a sling under the head of the talus bone, basically holding up the keystone of the medial arch.
So if that tears?
That's a very common cause of acquired flat foot, or Bess planus. Shows how crucial that one ligament is for the foot's whole structure and function.
It really does. You can see how knowing these specific nerve paths, muscle actions, even ligaments, plus those handy mnemonics.
Yeah.
It's not just about diagnosis. It helps you appreciate the sheer mechanics of how you move.
Absolutely. This is anatomy coming alive, explaining function and dysfunction right there in your own body.
Wow. We have covered an incredible amount of ground in this deep dive, pulling from Anatomy Revision Edition 8.pdf.
We really have, from that intricate dance of embryonic development.
Yeah, and it's sometimes surprising results.
To those hidden but critical anatomical spaces.
And the precise, but sometimes very vulnerable, pathways of the nerves controlling our limbs.
And the main takeaway, hopefully, is that this knowledge isn't just for specialists.
No, definitely not.
It's really like having a living map. It helps make sense of health, of disease, and just appreciate the incredible complexity and resilience of our own bodies. Understanding these details gives you that deeper why behind what we see, what we feel, what goes wrong, and what goes right.
So here's something to mull over as we finish. Next time you hear about a medical condition, maybe something someone you know is experiencing, or even just a weird twinge or sensation in your own body, how might thinking about the underlying anatomy, maybe some of the connections we talked about today, change how you see it? Could it spark your own curiosity to maybe dig a little deeper?
A great thought to leave with. That curiosity is key.
We hope this deep dive has sparked some of that for you. Thanks so much for joining us.
Yeah. Thanks, everyone.
We'll catch you on the next deep dive.